the next talk. So it's by Dr. Jecko Thachil. So I would request Dr. Ramaswamy, sir, he's a senior consultant at Astronomicity, to introduce the speaker as well as the panelists. Jecko is he's from UK basically, but he's traveling in Sri Lanka with some charity work. So he will be parallelly joining us. It will be recorded, already pre-recorded, and he will be joining us parallelly. So over to Ramaswamy.
Thank you, Shinto, for giving this opportunity. And for the first time in Kerala, we are doing that international workshop, and that's a credit goes to Dr. Shinto, and that too in the doorstep by the distinguished, eminent faculties from the international area, and that too it is a webinar. So that all because of the COVID era that we are facing it. So without covering the COVID pandemic topic, we cannot end up the sessions. So, and that too pertaining to our hematology forum. So COVID coagulopathy is the priority which we need to discuss today. And there is none other than Dr. Jecko Thachil will be the person. And if you just Google it, you will come to know the eminent personality of his academic status. And you will come to know how many publications to his credit in the COVID pandemic itself. In fact, one of the articles he presented with Dr. Alok Srivastava also, whether it is a pulmonary embolism or a microthrombi, whatever is a pulmonary microthrombi, whatever the things may be, which is causing the etiology of the coagulopathy. Without wasting the time, I would like to invite Dr. Jecko Thachil, and he is a consultant in hemostasis and thrombosis, and also honorary senior lecturer in prestigious Liverpool Institute of Tropical Medicines. And he has the research update is on platelet interaction with the white blood cells in the inflammation in the context of the sepsis, and also the newer therapies in hemophilia and anticoagulations in the kidney diseases. And he had more than 200 peer-reviewed publications in the indexed journals, and he is a reviewer for 25 prestigious journals, and he has edited and written in the various textbooks, including the hematology in critical care medicine and handbook on venous thromboembolism. With this short introduction, I'm proceeding to, I'm handing over to Dr. Thachil. I hope he is joining online, or Dr. Shinto?
He'll be joining online soon, because he has, since he's traveling, there is some range issues, but we will play the, talk will be played now. And the panelists, you can also introduce a panelist also. We can, after that, we have a discussion.
Yeah.
Thank you, moderator, for inviting me to do this talk. I also want to thank Dr. Thachil for this kind invitation, and I wanted to say how impressed I am with his work in Baby Memorial Hospital. So my topic today is coagulopathy in COVID-19. What I'll try to present today is mainly how much things have moved on about the understanding of coagulopathy, and I'm sure most of you are familiar with the management of it, in that you actually give anticoagulation in many patients. So I'll start off by going to the basics. The basics is that what does happen when thrombosis develops in a human being, or why do we have a blood clotting process in us? So it's a well orchestrated process. It involves all blood cells. That's a very key point. It involves red cells and white cells, something which is often forgotten when we look at the whole pathophysiology of coagulation in any setting. Now, why do we have hemostasis? It's to prevent the blood coming out of our important blood vessel, because it's the most important nutrient. And the clotting process should be limited to the site of injury. So it should not grow, which is why we have the anticoagulants like antithrombin, protein C, and protein S. Because if it continues to grow, then it will cause interruption of the blood flow and causes ischemia. However, in addition to stopping the loss of our most important nutrients in the blood, it is also an anti-defense mechanism. It stops microorganisms like bacteria, fungus, virus, of course, in this setting, entering the host. So it's forming a barrier in stopping infections coming in. So in other words, the clotting process is anti-infective. And this is something which has been known for many, many years. So if you look at the horseshoe crab, one of the basic evolutionary animals, they have the immune system and the hemostatic system coming together as the same one. And it used to be called hemolymph. However, the more evolved we have been, and with animals and human beings, these started diverging and became the immune system and the hemostatic system. However, they are still linked to each other. Why is this relevant in COVID? Is because, as we all know, in COVID, the main problem happens in the lungs. And we have a hemostatic system. We have a clotting system, which is specific to the lungs. And why do we have that? Because we are constantly exposed to infections which come in from outside through the respiratory tract. We want to stop the infection spreading into the systemic circulation. You could also think in this respect that we have a GI system, GI clotting system, because we are constantly exposed to microbes through things we consume, food and water and drinks. But specifically to COVID, this is a bronchoalveolar hemostasis, a clotting system in the lungs. And this is specifically comes to play in COVID-19, where the SARS-2 virus goes into the lungs, mostly 90% of virus's entry is through the respiratory tract, and it causes inflammation. And one of the commonest words used in the setting is called cytokine storm. For me, this basically means that the immune system is dramatically activated. And as we already discussed, it activates the clotting system and it causes immunothrombosis. However, I want you to remember one specific thing here. In COVID-19, one of the first processes, especially from a hemostatic point of view, is pulmonary microthrombi. And it's not pulmonary emboli. There's a big difference between pulmonary emboli and pulmonary thrombi, where emboli or embolus, as you all know, is something which comes off from elsewhere, usually the lower limbs. In COVID-19, the thrombotic process actually starts in the lungs. It doesn't start elsewhere, and usually is small clots, which you can't pick up sometimes unless you do very sophisticated imaging techniques. It could cause problems with ventilation and perfusion, something which has been discussed a lot in the anesthetic literature. The other pathophysiological process which is relevant for COVID-19 is the invasion of the vascular endothelium by the COVID virus. And one of the terms used here is called viral sepsis. And remember, the endothelium is like the skin, the organ which is everywhere. So endothelium is present in every part of our body. And it causes inflammation of the endothelium or endothelialitis, or it can cause pathological transformation of the endothelium, which can be called endotheliopathy. This also typically causes coagulation activation, which means that the clotting process is not limited to to the lungs. It can affect the kidneys, coronary, cerebral, and we have had patients with limb ischemia as well. Now, as hematologists, we like our blood tests, so let's go into some of these tests, and we'll start with D-dimers. And I felt quite disappointed that I didn't take any shares in companies which make D-dimers, because I would have been probably a multimillionaire by now, because now D-dimers is done in every patient pretty much all over the world. And may I politely say to all of you that please do not do D-dimers in most patients, because it's of no use at all. Let's look at COVID-19. This is a paper from China which came out very earlier on. This is published in Lancet. And you can see here is that if the D dimer goes up, the survival is poor. So higher D dimer means poor survival. The second bit here is that if the D dimer was measured repeatedly, and if it hasn't gone up, the survival is better. But if it's continued to go up, then the survival is worse. Now, this brings me to the question. I've just said that you shouldn't be doing D dimers in most people. Why is that? Because this D dimer increase is not signifying thrombus formation. That's the key thing which I want you to remember. D dimer increase does not equal to thrombus. And what is happening, especially in patients with acute lung injury, is that in addition to the inflammatory proteins which leak into the alveolar space, the clotting proteins, which is also inside the blood vessel, will leak into the alveolar space. That includes fibrinogen and thrombin. And a clot will happen in the intraalveolar space. And it forms a scaffold for inflammatory proteins to sit on it to do the purpose of inflammation. And when these intraalveolar clots are broken down, it causes D dimers to go up, which means that intense inflammation, may it be in the lungs, may it be in the gut, may it be anywhere, the D dimers will be up. And once again, it does not mean thrombosis. They are raised due to intense inflammation. And that is why in COVID-19, it correlates with mortality. Unfortunately, D dimers is still thought to be a marker of thrombosis, and that is not correct. And it's a very, very important message. So I tried to take a different spin on it because, okay, well, everybody's doing D dimer, and whatever I say or whatever anybody says, it may not change. So can we actually try and see whether it can be used for anything else? And what I've tried to show here is that in lung injury, most of the D dimers come from the extravascular fibrinolysis and a little bit from thrombus formation. So maybe it's possible D dimers is a marker of increasing acute lung injury, or ARDS. And I know that this conference has got many eminent oncologists, hemato-oncologists. So can we help them in aggressive solid tumors? There's D dimers, which forms in the extravascular space, causes fibrinolysis, which is why you see higher D dimers in patients with cancer. Of course, they might have clots, but again, the majority of the D dimers come from the extravascular fibrinolysis. In the case of cancer, it's in the stromal space or the cancer stroma. So that's about the D dimer. What about the platelet counts? I'm a big fan of platelet count because of some work I've done in what's called low resource settings, where the only blood test you can actually do is a CBC or an FBC, or full blood count, a complete blood count. And you can, as you all know, we can learn a lot from looking at the platelet counts. What about in COVID-19? Similar to D dimer, if the platelet count drops, it's a bad sign. If it stays normal, it's a good sign. But the important thing here is the decrease in platelet count, not one platelet count. And the lowest platelet count in majority of patients with COVID-19 has been 49,000. And if a person has got a lower platelet count than that, it is most commonly caused by immune thrombocytopenia. There has been a huge amount of research on how platelets are involved in COVID-19, and that's been published in Blood and other eminent journals. And SARS-CoV virus has been detected in platelets. There's lots of markers for platelet activation, and platelets also aggregated faster. Now, there's an important word: platelets aggregated faster in COVID patients. Why might that be relevant? This is a study from a setting of DIC, or septic coagulopathy, where also, this is in COVID, but it also mirrors what happens in septic DIC. So we have patients' von Willebrand factor levels going sky high, depending on severity of COVID. The Adams 13 activity is going down, but not as much as with von Willebrand factor antigen. But the key thing here is the ratio of antigen to Adams 13 activity. If that ratio is higher, the mortality is higher. That's a key thing. And clinically, in more simple terms, this has been shown with this case report from Ted Walkington, who looked at outcome of a patient who developed problems despite being on heparin when the platelet count started dropping. So the key time where we need to be bearing in mind is not the count, is the decrease in count. And you can see the D-dimer starts going up at that time because there were microthrombi happening and the worsening of the situation. And the pulmonary embolism actually happened when the count started dropping. So the clot might have started happening here and was picked up there. This is despite prophylactic heparin. So I'm trying to show this in a slightly different way. I've shown here a vascular wall. This is vascular endothelium, and the endothelium is activated in COVID-19, which means that it will release lots of von Willebrand factor, which is a classical feature of any inflammatory conditions. And if there's an inflammation and high von Willebrand factor, it binds to platelets and causes microthrombi. The issue is, how do we pick up microthrombi? It is an organ impairment. So you have renal impairment, cerebral confusion, in quite drastic cases, coronary thrombi, and sometimes pulmonary embolism, pulmonary thrombi. So the clinical manifestation of microthrombi from platelet aggregation is renal impairment or sometimes liver impairment, cerebral confusion, and in more dramatic cases, coronary and pulmonary thrombi. So that's with respect to blood test. I am not going into clotting screen. I don't think clotting screen is useful in most patients, and it should be not done in most patients with COVID or not COVID. What about anticoagulant treatment? So this is a figure I created in the beginning of COVID to show how you might want to look at the hemostatic system and coagulopathy in COVID. So if you want to do the blood tests, the D-dimer and PT and APTT and platelet count in early stages, which might happen in patients who are might be a little bit have the respiratory symptoms, they will start having microthrombi forming because they have inflammation in the lungs. However, if the inflammation is intense or a host response to the virus is intense, they start forming a lot of pulmonary microthrombi, which means pulmonary thrombi. So this is where the problem starts coming. And here, as you can see, the D-dimer is already raised in this person, but they may not even come to hospital. But here, it is markedly raised because there's inflammation plus thrombi, which is why D-dimer is high. And the platelet count started coming down. And then if we are not dealt with this properly, which is not easy, I understand, then this clot process, which has happened in the lungs, will spill into the circulation and causes clots elsewhere and mortality. This is why we wrote this. This is the first guideline in the world which is written for COVID-19 coagulopathy. I mean, I was fortunate to be the lead author, and it's been cited almost 2,000 times in the last 2 years. So we use these markers and said that depending on these markers, you should admit the patient, and if they're not, then not to be admitted. This was written at a time when hospital beds were very limited, and we had to make that judgment about how many patients should be admitted. And we said in all patients who are admitted, doesn't matter what the levels of D-dimer or anything is, to start prophylactic dose low-molecular heparin. This is from March 2020. Then we started noticing that prophylactic anticoagulation does reduce risk of mortality. So that's why we recommended it, and so also American College of Cardiology. However, papers started coming out that patients can fail prophylactic anticoagulation. And we know that anticoagulation does not always prevent arterial clots, and it wouldn't treat microthrombi. Then there came a flurry of randomized trials involving thousands and thousands of patients. I picked up 3 of them, ATTACK-RE, MAPCAP, and ACTIV-4A. And it showed that therapeutic anticoagulation increased mortality and bleeding in severe cases. However, therapeutic dose increased organ support-free days, as in so it's a better outcome, and reduced mortality in moderate cases. So in severe cases, full dose is not good and increased bleeding. In moderate cases, it is better and should be given. So how do we dose it for practical purpose? Clearly, all patients who needs admission needs to be given prophylactic dose. Therapeutic dose should be given to people who have supplemental oxygen, but not yet receiving high flow oxygen, CPAP, and non-invasive or invasive ventilation. No therapeutic anticoagulation in severely ill patients with these criteria unless they have a proven clot. And they should be for a minimum of 14 days or until discharge. And this is one of the papers published in New England Journal of Medicine, and you can see this big difference that the therapeutic dose, it was better than compared to usual care with moderate disease, and organ support-free days was better with therapeutic anticoagulation. So it made me think, it doesn't make sense to me why a person needs higher anticoagulation when they're not unwell, or at least not severely unwell, and lower anticoagulation when they are severely unwell. And my explanation is based on this. It's based on this balance between anticoagulation and inflammation. If you got intense inflammation, we need higher doses of heparin to dampen that inflammation, because remember, heparin is an anti-inflammatory in addition to an anticoagulant. That's why higher doses are required in moderate cases. And I'll come to intense inflammation in a second. They also showed that in severe patients, if you give therapeutic anticoagulation, there was more bleeding. You would expect that a higher dose will help these people, but they cause more bleeding. Why might that be? That's because in inflammation opens up the endothelial gap junctions and let blood come out. And in such people, if you give very high doses of heparin, it will make it worse. So the reason why therapeutic heparin causes more bleeding in critically ill patients is because of the associated very high degree of inflammation, and which causes hemorrhage due to opening of endothelial gap junctions. And to finish off, I'll talk about the before and after hospital antithrombotic treatment. This is data published fairly recently on the risk of symptomatic thromboembolism in mild and moderate COVID-19. In moderate COVID-19, the risk is very high. In mild, it wasn't much different, although the definition of mild and moderate is not easy. This is after discharge. You can see that the risk of this is pulmonary embolism and DVT. The risk of pulmonary embolism remains high in patients in COVID-19 admitted to hospital after discharge. Then came this pivotal trial, at least from the point of view of prophylactic what to do in a person who are discharged, called the Michelle trial. And you can see a clear benefit for using rivaroxaban compared to a placebo in these patients. And they said that in patients at high risk discharged of the hospitalization due to COVID-19, you should give rivaroxaban 10 milligrams a day for 35 days because it improved clinical outcomes if you don't give it, compared to if you don't give it. Now, there are lots and lots of trials using various things, heparin, DOACs, fibrinolytic therapy, aspirin, and different settings as well. I've summarized these various things which I was part of many of these discussions in the beginning, but none of them really took off to the extent that it should be done for lots of people. I mean, most recent trial on using aspirin in patients when they're at home prior to admission to hospital was not beneficial either. Now, to come to the end, there are still questions remaining. So if a person's got COVID-19 and they're at home, Do we give them antithrombotic prophylaxis? Do we give them aspirin, DOACs? You clearly can't give them heparin. It's not easy. When they're admitted, who actually gets prophylactic dose and who gets treatment dose? I mean, yes, it's based on oxygen, but in half of the world, this need for oxygen is not easy to measure. In an ICU, can we give high prophylaxis? Should we give them aspirin, clopidogrel, or if they can't take orally, cangrelor? Will that help? And post-discharge, yes, we know that 35 days of antithrombotic might be beneficial, but does that matter to all patients? We need to know more. And thank you.
Thank you, Dr. Jecko. Excellent. Love to hear once more, actually, if time permits. And for the want of time, I would like, because we, at least in our state, hematologists are not actively participating in the day-to-day activities of the patient. The right persons to be discussed with you is our infectious disease specialist, as well as the critical care physicians and the pulmonologists. I would like to invite the panelist, Dr. Anup Kumar, who is a senior consultant and chief head of critical care from Baby Memorial Hospital, Kozhikode, and also Dr. Nitin Bansal, consultant from the Department of Infectious Disease, Rajiv Gandhi Cancer Center from New Delhi, and also Dr. Mohammad Niaz, associate consultant, Department of Infectious Disease from KIMS Hospital, Trivandrum. I would like the panelists to join. Go ahead with your experience and the questions which needs to be.
Can I start?
Go ahead, Nitin.
Yeah, I have a lot of questions, but I will just stick to two. First is you talked about lot of about COVID, but as we know, COVID has also changed. So, what is the role of the virus itself in this immune thrombosis? And second question is, can we rule out immune thrombus or any sort of thrombus by doing an angiography?
The first question is a very interesting question. I wanted to put that on the slides because with the Omicron variant, we saw much less thrombi. And there could be various reasons for that. One is that the patient was actually getting anticoagulation. They were getting dexamethasone if they were admitted or in ICU. So the treatment landscape had changed, but very, very, very few patients actually had a thrombi because we were actively looking for it. The second question about angiogram, there is some suggestion about using ventilation perfusion scan, especially perfusion scan as we do for pulmonary emboli, as being able to pick up pulmonary microthrombi if it was kind of more sophisticated. So the latest SPECT VQ is what our radiologist or nuclear medicine specialist said that can be used to pick up pulmonary microthrombi. But I don't know whether you can do any other angiogram as such, and my expertise in that area is very limited. But this was a question which came up very early on when we used to say about the microthrombi to see how we can pick it up. This is also currently being discussed in patients with the long COVID, because there's a thinking that long COVID is caused by pulmonary microthrombi, which obviously is not being picked up by scans. So very interesting questions.
Thank you.
Can I ask next question?
Excellent
talk. My question is regarding the Michelle trial. It has its own problem. It was a low sample size study. And second, it has a higher degree of thrombosis when we compare to the usual rates of thrombosis. So how will it change the practice? Are you going to anticoagulate all hospitalized patients post-discharge, or will you select a particular group of patients for anticoagulation?
Well, our policy since the beginning, some say sort of April 2020, was to anticoagulate all patients with rivaroxaban 10 milligrams if they did not have thrombi in the hospital. So I don't think it will change that we give a different dose, which is probably what one of the discussions has been. But the key problem here is how do we pick those people who are going to get clots after discharge? I mean, obviously what we can do is to give rivaroxaban 10 milligrams because it's a fairly easy thing to do and people can take it. So it's a important question, but since the landscape has changed now with, well, I hope that COVID is hopefully settling down with Omicron, which is certainly settling down. I think the thrombi issue at the discharge was much less. There is a new guideline which I'm part of, which is coming out possibly in the next 2 to 3 weeks, where we will be talking about what is the current recommendation. And I shouldn't say this loudly, but the current recommendation still stays as only after discharge for 30 days, because that's the only randomized trial which has actually been. So I agree with your issues about flaws in the Michelle trial. So far, there are a couple more trials running at the moment with the Pixaban, and I think it's Eoxaban. Maybe I'm not sure about the second one, but which is going to be reported fairly soon.
Any use for the improved VT score? That is something that used in the Michelle trial also. And we were also using that improved VT score to predict high-risk patients whom we can give rivaroxaban or apixaban.
Dr. Jecko? I think we lost him. Dr. Jecko?
I think we have some connectivity issues.
Yeah, connectivity issue. Even the previous question answering, there was a break. I think he was in the moving. This one.
He has joined back.
He's joined back now.
Dr. Jecko?
So mute.
Hi, sorry, I'm back here. Sorry. I think
Yeah.
there was
hear
a
my
question which, yeah, sorry, carry on.